Hi, I'm Dr. Lili, and today we're going to talk about babies that spit up.
When the doctor says my child has a condition, I'll learn more at my pocket pediatrician.
Hi, I'm Dr. Lili, and today we're going to talk about babies that spit up. So I was in a grocery store with my 4 children, and a young man who was there kind of in the produce aisle working came up to me and said, "Ma'am, I just want to let you know you have a little spit up on your back." And I just kind of laughed because I was like, I always have some spit up on my back, because every time I would hold my baby up, he would just sort of spit up right down my back. At that point, it seemed like for the last 4 years, I always had some sort of spit up on me because I always had a baby on me who was spitting up. So the young man looked kind of horrified and went back to his produce, and I walked on with my children, realized normal people don't always walk around with spit up on them, but it was just kind of part of my life at that point. So this is one of the very common things I see parents for. About 50% of babies have significant spit up. And almost all babies have it to some degree. It just doesn't always come up. When you look at the anatomy, milk goes in the mouth, down to the esophagus, and then into the stomach. There's a sphincter on either end of the stomach. There is the lower esophageal sphincter, which is at the top of the stomach, and then the pylorus, which is at the bottom. And so when the milk goes in, those two are supposed to close off, and the stomach starts squeezing and churning and basically digesting the milk. But in babies, that lower esophageal sphincter is often very weak. When the stomach starts squeezing, that little ring is not quite tight enough and milk starts shooting right back up. A lot of times it stays within the esophagus. Sometimes it'll shoot right back up and the baby just spits up without any rhyme or reason. All of a sudden there's just spit up all over the baby. They don't even notice sometimes. I could say my kids did it so frequently they probably didn't even notice most of the time. So about 50% of babies will spit up. The incidence will kind of peak around 4 months. So if you look across all 4-month-olds, about 50% of them are spitting up enough that their parents are noticing it. And if you get to about 1-year-olds, then only about 5 to 10% are. So at some point between 4 months and a year, that little sphincter is going to close and tighten. From that point on, they will not spit up nearly as much. All 4 of my kids did this, and I remember exactly the time when they went from spitting up all the time to just one day it just stopped. And all of a sudden this baby who was spitting up just wasn't spitting up anymore, and it was kind of great. So it will end. There is hope. Your 5-year-old is not going to be spitting up on people, hopefully. I just wanted to talk to you guys a little bit about what you can do with treatment options and things like that. So when we look at spitting up, the real word for that is gastroesophageal reflux. You can have gastroesophageal reflux, or you can have gastroesophageal reflux disease, which is GERD with the D on it. Reflux happens in almost all babies, and it doesn't really cause symptoms. Sometimes they are what you call happy spitters, but most of the time they're not bothered by it. Other people may be bothered by it, but the baby themselves is happy. When you get into having symptoms like pain, difficulty gaining weight, other things like that, that's when you call it gastroesophageal reflux disease. Sometimes in infants, what you see is something called Sandifer sign, where your baby is sitting there looking happy and fine. All of a sudden they arch their back. As they're refluxing, they're arching their back, crying, trying to make that pain stop. That's kind of the classic painful reflux. That's when you start thinking a little bit more about more intensive therapies. But either way, when you start out, the first things you want to do are mechanical, and these are very important. When you feed your baby, one, you don't want to overfeed. So look at the guidelines for your baby's weight and figure out how much your baby should be eating. So very often when I have people come in and tell me my baby's vomiting, I'll say, "Oh, okay, how much are you feeding them?" And they'll tell me 4 ounces. And it's a 1-month-old baby who should probably be taking 1.5 to 2 ounces, and instead they're taking 4. When you look at the baby's fist, that's about the size of their stomach. When you think about putting 4 ounces into that, there's just no place for it to go, and they can't digest it fast enough, so it's got nowhere to go but up. Smaller, more frequent feeds are the first step. You always want to burp your baby, and it actually helps to keep your baby upright for 30 minutes after feeds. This, to me, in practice is tough, especially when you're doing all the middle of the night feeds with your young baby. If you get up and you're breastfeeding or bottle feeding, either one, and you're trying to stay awake, get this baby to drink, your first instinct is when that baby finally drifts off to sleep just to put them back in their bed as quickly as possible. But if you lay them back down and they're on a flat surface and they're not really burped, the first thing they're going to do is just kind of spit up that whole feed, cause a big mess, and you're going to have to start all over. So keeping the baby upright is really important. I like to kind of put them up a little bit on my shoulder so that they get the pressure of my shoulder on their tummies, and just burp, burp, burp right here on the shoulder, and that way you're getting some of that air out. And I don't lie the baby down until I've had at least 2 good burps. I mean, I remember being up and just counting as I'm patting their back. 1, 2, 3, 4, going up to 100, 200, waiting for that burp, and all of a sudden that burp would come, and I'd say, "Oh, thank goodness I can go lay down the baby and go to sleep." myself, but it is something that really helps. And especially in the daytime too, it's a lot easier for you to just sit there and hold the baby and keep them up when you're not tired. Now, if you're tired and you think you're going to fall asleep, then the better thing to do is just put the baby down, and if they vomit, they vomit. But falling asleep holding a baby is also pretty dangerous and can cause risk of suffocation and other things. So if you're really so tired that you think you're going to fall asleep, just go ahead and lay your baby down. But if you have it in you to stay awake, then you can stay awake and try to keep them upright for a bit after that feed. Also, sometimes the baby might actually have a milk protein allergy. So if your baby is having a lot of symptoms and you're breastfeeding the baby, you as the mother may want to eliminate all dairy from your diet for 2 to 4 weeks and see if that has an improvement. Anytime you're doing an elimination diet, remember that if you're pumping and you're giving milk from before, you're not going to see that benefit. So if you do start an elimination diet, make sure you're only feeding the baby pumped milk from the time that you started eliminating, so that you know that you're not giving the baby milk that had the dairy in it. Also, avoiding tobacco smoke is important. So if anybody's smoking in the home or you as a mother are smoking, stopping smoking can also reduce these symptoms significantly. Now, somebody might tell you to lay your baby down on the stomach and that would reduce the reflux. That's true, it does, but the risk of sudden infant death syndrome is so great that we will never recommend lying your baby flat on their belly. The risk is just too great. The back to sleep program is very important. So you always want to lay your baby on their back to sleep, because that's definitely the safest thing for your baby. When we talk about medications, there are acid reducers and antacids. Antacids would be things containing aluminum and calcium, but they can have some toxic effects on children and can be hard on their kidneys. So we don't usually recommend those as a first-line therapy. So the acid reducers, like proton pump inhibitors and histamine blockers, may be recommended in the case of a child who has actual gastroesophageal reflux disease, but they also have side effects. And there has been some talk recently of a new study that came out suggesting it was associated with more risk of allergy and immunological problems later in life, which makes sense because it kind of works on those same pathways. That's not to say we should never use them, but we don't want to use them unless we have exhausted all the other possibilities. That said, in severe cases, like where the children are not gaining weight and they're having a lot of significant pain. So if your child is having painful reflux like that and the mechanical things haven't worked and then the medicines haven't worked, sometimes surgery can be an option, but we really try to reserve that for the most extreme cases. So the mainstay of treatment is smaller, more frequent feeds, keeping your baby upright, making sure they burp well. I do want to add that when I say keeping your baby upright, I mean you holding the baby up. I don't like rock and plays for babies to sleep in or car seats or any of those things, especially in younger babies. Their heads are so big, and if you have the baby sleeping in a position where they're really tilted up at a 30 to 45 degree angle, their head can actually just bend forward and close off their airway. And kids have died sleeping in car seats that weren't in the car. The car seat's designed to be used only in the car. You shouldn't have your baby in an infant carrier car seat sleeping unless they are in direct supervision and you're watching the baby constantly. The same thing for rock and plays, bouncy seats, all of those things. The baby should be observed by you. If they do fall asleep in those, you can be in the room awake with the baby, but you should not leave the room or leave the baby unsupervised in those settings in any way. Sometimes it's just as simple as the weight of the child's own head turning their neck and they are unable to breathe. They can actually asphyxiate or die in those kind of seats. So parents whose children reflux often just get to the point where they're desperate. They want to do anything to let that child sleep. But even though it might help the reflux, the safest place for your baby to sleep is going to be in a flat crib on their own, just a sheet, nothing else in there. And that's really going to be the best way for your child to sleep. You may want to try an elimination diet. Milk and eggs can be two of the first things you eliminate and see if your baby's doing better with those. After mechanical things, the medications are a possibility. And if the medications fail, then surgical interventions can also be a possibility. Have hope. Your child will outgrow this. I can tell you I no longer have that white stain on my left shoulder that I thought was just going to be part of my wardrobe for the rest of my life. They do outgrow it, and there is hope. I'd love to hear from you. Please comment below. Let me know what you think, what worked for your baby. Also hit that little red subscribe button so you get updated whenever I post new content. And I'd love to hear from you. This is Dr. Lili with My Pocket Pediatrician. Thanks for stopping by.
When the doctor says my child has a condition, I'll learn more at My Pocket Pediatrician.